Yeah, I'm a practicing respiratory and intensive care consultant at Glenfield Hospital in Leicester. In the next few minutes, I'm just going to talk about the impact of winter pressures in a hospital respiratory department, and obviously the treatment of tobacco dependency to try and reduce those pressures. I'm sure all of you will be familiar with this type of slide. We see it all the time. This is the deaths by week starting in March. These are the excess deaths. In the yellow part of the bars, you can see the deaths related to COVID-19. But in the white part of the bars, you can see the excess deaths related to other causes. Now, as a respiratory specialist in my hospital, I know that a large proportion of those excess deaths will have been due to respiratory causes, including things like lung cancer, pulmonary fibrosis, COPD, etc., as well as other types of deaths like cardiovascular death, etc. And many of those will also be smoking related. And my big fear going forward is that we're going to have a lot of excess deaths related to non-COVID causes that are preventable. And so one of the ways we can prevent them is to treat tobacco dependency now in the hope that we reduce deaths, which I think lines up with what Paul Aviard was saying just now in terms of all-cause mortality. Now, if we look at referrals to respiratory departments, this is the planned referrals, if you like, from GP practices. This is a measure of e-referrals. And again, on the left of the slide, you can see that there are about 5,000 referrals each week before the last lockdown. And since then, referrals have picked up, but they've sort of plateaued out and about a couple of thousand referrals lower per week than previously. Those patients haven't gone away. They're still there. We're storing them up in the community. They will be coming. And again, the question for me would be, okay, so what can we do now to reduce these referrals coming through into hospitals and specialised services? So that's elective referrals through clinics and specialist clinics in respiratory medicine. What about unplanned admissions? Well, this graph, these two graphs look at two different things. So just to reorient planned admissions to respiratory over the last few years, and you can see that it's very slowly gone up. These are emergency admissions. Readmission rates remain around 12%. But the bottom line is, compared to many other specialities, respiratory unplanned admissions have gone up, if anything. Now, how does that translate into bed days used? So if you look at the bottom left graph, these are the bed days used in respiratory medicine for unplanned admissions, and these have gone down slightly. However, the 0-day admissions, so attendances on things like clinical decisions unit or medical assessments units, have actually gone up. So actually what's really happened is that patients are coming into the hospital as unplanned emergency attendances and going home again. And there hasn't been much change in the last few years. So there's more that we need to do to prevent these unplanned admissions and emergency presentations in hospitals. Now, the British Thoracic Society have done two smoking related audits in 2016 and 2019. And if you look at the left-hand side of the slide, they measured the smoking rates in elective patients, inpatients in hospitals, as well as emergency admissions. And you can see that the percentage of current smokers attending electively as inpatients was about 19%, and 50% higher was well into it by the time we got to 10%. And that was similar both in 2016 and 2019. if you look at smoking prevalence across different hospital specialities, so whether they're a surgical specialty, respiratory medicine, obstetrics, other medical specialties, you can see on the far right-hand side of the slide in 2019 that smoking prevalence rates in these inpatients across the hospital was well above 20%, highest in respiratory medicine, but actually pretty uniform across the hospital. So it doesn't really matter what hospital speciality you're in, you're going to have smokers on those wards who could be treated for their tobacco dependency.
Hi, Sanjay. So
Hi.
there's a few people who've just said they're having a few issues seeing your slides. So I'm just going to try and share your screen again, just to make sure that that corrects. You should just get a pop-up in a second.
Carry on, Sanjay. They're just small, but I mean, your talk's so excellent. We just get an overall picture, but carry on.
Okay, so I'll show my screen again. I've done that.
That's great. Thanks, Sanjay.
Okay, so you can see the whole slides now, can you?
Yeah,
we can.
Yeah, brilliant. Okay, fine. So so far we've talked about the fact that we know that smokers are admitted to every part of the hospital, that they account for a significant number of unplanned admission to respiratory medicine, as well as elective referrals to respiratory medicine. Now, what about the cost of smoking? Now, this is data taken from the RCP report in 2018, hiding in plain sight. And we calculated the cost of current smokers attending hospital across different specialities. So when you looked at cancer care, inpatient cancer care amongst current smokers, it was 174 million. And then for respiratory medicine, 168, the cardiovascular disease, 157 million. So significant cost of current smoking. And this is per year. And actually, if you look at the far right, you can see the cost of NHS staff who currently smoke due to absenteeism, lost productivity, and requiring NHS care themselves was also pretty substantial. So these costs are recurrent, they're every year, they account, and if you look at UK wide, over £1 billion a year. And these are recurring costs at a time where we're all obviously very aware that we need to use money to treat COVID and other things in society. So this is money that we shouldn't need to spend. Okay, so what works? We've sort of explained what the problems are, the cost of the problems, and the breadth of the problem. Well, if you ask yourself the question, are we currently treating tobacco dependence very well? I think the answer is not really. Again, if you look at the British Thoracic Society audit, 2019 compared to 2016, around 25% of patients in the audit smoked. Only 16% were referred to a stop smoking service. 30% got NRT. About a third of hospitals had a stop smoking practitioner. Although all of the hospitals, you could prescribe pharmacotherapy, but very few were actually doing it. And very few hospitals actually offered training for tobacco addiction. So
it was a bit higher than truthfully.
And is low. So what can we do? Well, and of course, many of you will have heard of the Ottawa model of smoking cessation. This was a trial done in Canada where systematic treatment of tobacco dependency was used, whereby every inpatient smoker was seen by a smoking cessation advisor. They were counselled, they were given pharmacotherapy on an opt-out basis, and they were followed up when they got home, either with automated messaging or face-to-face messaging if they relapsed. And they looked at outcomes including mortality, ED visits, GP visits, readmissions, and they found benefits across the spectrum. And in the RCP report a couple of years, we costed these out. So when we applied the reduction in readmissions, in A&E visits, in GP visits, using NHS costs, just with a 27% uptake of smoking cessation treatment, we found cost savings of 84 million each year. And if you halve that, it's half the saving. But these are substantial savings to the NHS by treating tobacco dependency, even with the cost of treating tobacco dependency taken into account.
Sanjay, that's 10 minutes now, so if I can
ask
okay,
I've got just a couple more slides. So just very quickly to say, in Manchester, they've implemented it. So just because it happened in Canada doesn't mean it can't be done in the UK. And in Manchester, with the Cure model, they've done this pretty easily. This is just to say that smoking cessation treatment in the UK, well, in England, sorry, is shared between local government, and now the NHS is going to do more with introducing tobacco dependency through the NHS long-term plan. But for people on the call who are planning smoking cessation treatments in hospitals, you're going to need to follow the money. So the money going from central funds to local CCGs, STPs, to providers in hospital. This is the key slide. Follow the money.
Thank you. So follow the money, everybody. We'll have time for further down the track. Amazing. Follow the money and invest in smoking cessation services. So I'm going to move us now to Joanna Feeney, who's going to talk about system-wide implementation of NICE guidelines. Now, Joanna is a smoke-free NHS strategic manager at FRESH, the North East Regional Tobacco Control Centre, and she's going to present on how they have brought partners together to deliver comprehensive implementation of NICE guidance on treating tobacco dependence and the tools that can support other local areas. So Joanne, over to you for your 10 minutes, and off you go. Lovely to see you. Well, I can't actually see you at the moment, but I'm sure I will be soon.
Brilliant. Can you see my slides?
Yeah, we can.
Yes, excellent. Okay. So as you said, I've been asked to kind of talk through the experience that we've got here in the Northeast of introducing a systematic approach to implementing NICE guidance. So in the Northeast, we've made really good progress at reducing prevalence to its current rates, which is 15.3%, and this is down nearly half since 2005. But obviously, smoking still remains the key cause of premature death and disease within the Northeast. The ICS Population Health and Prevention Board set out their two key priorities, and treating tobacco dependency was one of these. We set up the Smoke-Free NHS Treating Tobacco Dependency Task Force as the delivery arm of the ICS to drive forward the treatment of tobacco dependency and implement NICE guidance within the NHS, and also to support the wider system approach to reducing smoking prevalence to 5% across the population. This ambition was endorsed by all the health and wellbeing boards in the region, and the task force is a multidisciplined group. It's co-chaired by the Director of Public Health in Newcastle and the Regional Clinical Lead for Tobacco, who is a respiratory consultant at the Queen Elizabeth Hospital in Gateshead. And on the task force, we have representation from senior leads in NHS trusts, mental health trusts, CCGs, local authority, PHE regional team, and FRESH. The task force was initially given the mandate to drive forward the regional action plan to support implementation of PH48 and for all trusts to be smoke-free as per the Tobacco Control Plan ambition by April this year. And this diagram just kind of illustrates the structure that we have within the Northeast that supports the implementation. So the task force there is obviously, as I say, the delivery group for the prevention work stream, and it oversees the implementation and monitoring and embedding of PH48 across the trusts. It links up with the Population Health and Prevention Board, supporting the wider system approach, but also the other work streams, such as making every contact count, the workforce work stream, population health management, and mental health. Within the task force, we have interdependencies with other groups, such as the ADPH Tobacco Commissioners Network, the local maternity system, the clinical networks such as Regional Respiratory Network and the CVD network. And the links with the Commissioners Network are really quite key because it helps to ensure that they're kept abreast of the developments within the smoke-free NHS, but it also enables the hospitals and the community services to work together to ensure that there are seamless pathways. We have a number of subgroups that have been set up to drive forward specific pieces of work, such as the Smoke-Free NHS Leads group, which brings together all of the kind of nominated trust smoke-free leads to promote what works, share best practice, and troubleshoot to ensure that there's a
hospital admission to intensive
despite the local variations. And we also have our primary care subgroup, which scopes out plans for systematic approach to very brief advice within primary care. Again, building on best practice, but coordinating between primary care and secondary care. And this helps us to also kind of develop those links into the CCGs and the primary care networks. But implementing smoke-free NHS and NICE guidance across the region has not been without its challenges. And to be honest, these were pretty consistent across all of the trusts. Initially, the challenge was about understanding what a smoke-free NHS was, that it was not simply about having a no smoking policy or signs that just kind of prohibit people from smoking on site, and that it was more about supporting the patients to be smoke-free and recognising that often when you see people smoking outside the hospitals, it was reflective of what was not happening in the hospital, such as identifying smokers and managing nicotine withdrawal with medication. And obviously that was something that Sanjay had kind of alluded to, and that was identified within the BTS audit. It was the responsibility of the trust as a whole, from the executive team down, and we needed to engage staff as to why it was important and why all staff should be aware and should be looking to identify smokers. It was a change of culture that needed to be embedded within trusts, and to do that we needed to have the dedicated time and resources to make it happen, and clinical leadership was seen as being a key enabler. To help change the mindsets, we've reframed the language from smoking cessation that was often kind of seen to be the job of the Stop Smoking Service.
Outcomes are incredibly rare.
To treating tobacco dependency, and this reframing helped us to engage with the staff across the system so that smoking was seen as everybody's business and is seen as a long-term relapsing condition that needs treatment, as opposed to it being a lifestyle choice that people just choose to do.
With COVID-19
was key, but you know, engagement proves to be difficult when it's not mandatory. So training has been added to local inductions, it's been linked with the ESR, and we have smoke-free champions that the trusts are using to disseminate information across all of the wards. And this has been supported by ongoing communications for staff alongside communications for patients and visitors. Another key challenge that was faced by most trusts was in relation to vaping, which continued to be a source of confusion, despite the clear guidance from PHE and the RCP. And this confusion acted as a bit of a block to ratifying and updating policies that encompassed pragmatic harm reduction approaches to vaping on sites. We also needed clear, simple referral pathways to ensure that medication could be ongoing for those who initiated within secondary care. However, within our region, we have 9 trusts covering 12 different local authority areas and 11 different stop smoking services, each with varying models of support, inclusion criteria and referral pathways. So to remove the challenge of this cross-boundary issue, all of the stop smoking services came together and agreed to be a single point of referral for their local hospital, which helped simplify the process for the ward staff. Despite the challenges, we still are continuing to make good progress. We recognise that it's a journey, but all of the trusts in the region have signed the National Smoke-Free Pledge. They've all committed to prioritising treatment of tobacco dependency and nicotine management, and have reviewed their policies and updated their pathways. All of the trusts have allocated both a senior leader, senior manager as a programme lead, and a nominated project lead. And we have a dedicated knowledge hub page that provides updates on key developments and shares experience for over 70 colleagues in the North East. And the work of the task force has not just been limited to facilitating the joint work within the trust, but also to other key stakeholders too. So we've worked closely with national colleagues such as ASH and PHE, and have contributed to the development of the PH48 toolkit, which contains everything a trust would need to fully implement NICE guidance, such as action plans, template policies, training guides, vaping guidance, medication processes. It's all there. Within our subgroups.
John.
Okay.
2 minutes.
No problem. Within the subgroups, we've also developed a variety of resources, and we've also developed modelling data for local trusts that have been looking at the benefits of readmissions, and these have been used to support internal business cases for resources. And we've developed a regional smoke-free NHS data collection tool and evaluation framework, which will help us monitor our process, our progress as we work towards implementing the long-term plans. There's been dedicated pieces of work within the primary care subgroups, including education sessions for both CCG staff, and we've developed a number of resources such as the communications toolkit, the vaping standard, nicotine management pathway, and again, this has all been to help with consistency across the region. So there's lots of work happened and lots of resources that have come together to support this. And I suppose, when the long-term plan was published back in January last year, the trusts were in the North East, we were already on our way to becoming smoke-free and implementing NICE guidance. And, our ICS as a region sees this as being the foundation to implementing the long-term plan. So I suppose just to kind of finalise, this is what our next steps are. We know that smoking can no longer be seen just as a public health issue or just as an NHS issue. We need to have this whole system approach in which treating tobacco dependency is every clinician's concern in both acute, secondary care, but also in primary care. And the whole system approach provides us with the opportunity to review our services, but also to target service provision to where it's needed and mobilise that clinical leadership. Sustainability is key. We need to ensure that we're monitoring and embedding PH48, especially during these difficult times, and provide feedback for staff. We need to ensure that our staff across the system have the skills and resources to deliver on it. So we're looking at a regional training strategy. And the long-term plan also offers us the opportunity within the ICS to drive change and to build on what we've already done, prioritise prevention and ensure that treating tobacco dependency is actually embedded into routine care. And this includes a systematic approach within primary care with the aim of starting treatment before somebody actually goes into hospital as part of a planned admission. And there's opportunities for us to join up commissioning to standardise treatment services across the region. And we're exploring how a tobacco compact between the ICS, NHS and local authorities would work across the patch to reduce the variations in provision. And I suppose just to kind of finalise, in a system-wide approach, we recognise that this is just the NHS's contribution to the smoke-free generation, but we does need to be part of a comprehensive tobacco control plan that is actually funded properly as set out by the roadmap for Smoke-Free 2030.
Thanks very, very much, Joanna. Fascinating, and I'm sure we're going to pick up on some of those questions and including what the confusion was about vaping, because I must say I'm confused what the confusion was. I'm sure that will come up. So last but not least, we've got Dr. Paul Slia-Lacorte, I hope I pronounced that correctly, who's a Senior Programme Manager for Prevention at NHS England. And Paul is going to present on plans for implementation of the NHS long-term plans commitment on treating tobacco dependence. So Paul, over to you, and I'll give you a 2-minute warning, as with everyone else.
Brilliant. Can people see the slides?
Yes, we can, and we can hear you.
Brilliant, brilliant. So thank you for asking me to come and talk today. So I'm just going to give a quick recap of the long-term plan, what that's all about, why we're doing it, before I get into a little bit more detail in terms of implementation. So just in terms of the long-term plan, there are 3 main commitments that we've put in relation to smoking, particularly that we want to make sure that everybody who's admitted to either a acute trust or to a mental health trust are offered smoking cessation support when they're admitted overnight. We want to make sure that offer is also available to pregnant women and to the partners, and also for higher risk outpatients, but with a particular focus on mental health, because we know the health inequalities there are so stark, is we want to make sure that they are able to access smoking cessation support as well. So just to reiterate something that Joanna's just said, this is the NHS's contribution. It's to build on the good work that's already happening across local authorities.
So this is the risk if
we know they're doing a good job in some difficult circumstances, and what we want to do is help promote what they're doing, but also to add to what they're doing to make sure that we can get towards the 2030 ambition of smoke-free society. So just to recap very quickly, I think Claire, Paul and Sanjay have covered this in great detail than me, but global burden of disease data ranks tobacco and the risk related to tobacco as the greatest or the highest modifiable risk to mortality in the UK, and that's something we want to tackle. Taking some data from NHS Digital and from the RCP report from 2018, people are a lot more likely to die from smoking tobacco than they are from other modifiable diseases such as alcohol. And just coming into the winter season, it's just to highlight that people are a lot more likely to get microbiologically confirmed influenza. So lots of pressure onto the NHS. Not only are we going to help patients actually beat their tobacco addiction, but also we're going to reduce demand on services as well at a time when obviously that is quite pertinent. So what are the interventions? Well, they're slightly different across inpatients and maternity care, because basically the maternity care will be support given through the antenatal period rather than when people are admitted as an inpatient. But essentially it's a no-brainer. It's just identifying who smokes, making sure that we give them some behavioural support, and then also make sure that we give them nicotine replacement therapy or other pharmacotherapy depending on what's appropriate for that particular patient, but making sure we personalize that care. We have a talk with that patient or that service user and understand what it means to them to stop smoking and how do we help them to actually take that forward. And when we talk about inpatients, we also need to make sure there's support there for when people leave hospital, because when people are touched an NHS hospital, in terms of an acute trust, they tend to only be in for 2 to 3 days and then go home. We know the balance of the NRT will have to be given in the community. So the idea is that the model is there. It can be adapted locally as long as people keep to the core components to it. So make sure that people actually deliver that bespoke face-to-face intervention, offer the NRT, but it can be delivered by different staff groups. It can be commissioned across boundaries. We're not precious as to who does this as long as it happens. And the idea is that everybody will have access to this by the end of 23-24. So what are we doing to actually implement it? Obviously things have been impacted by COVID over the last year. During 2021 we were supposed to be running early implementer sites. We're only just getting to the point where we're starting to kick those off now. We still want to run them for a year, and that will lead us into sort of the next 4 years where we're actually going to look at testing it during the early implementer sites and then having a phased rollout with increasing investment going into the system up until the end of 23-24 when money will be rolled into baselines. But just to make it clear that this is money that's going into system baselines, this is money that's going out into the NHS for people to use to deliver these interventions, and it will increase year on year. So year on year, different systems, different IPSs or STPs will be able to increase the amount of coverage within their localities, and they can concentrate that where they feel the greatest pressures are to start with. So what do we want to get out of 2021 and 21-22 now? Well, they're the early implement sites. We still want to test them for over the course of a year to get some decent learning out of them. We want to test the different methodologies at scale and across geographies. We need to understand how do we get to all patients, not just those ones with decent health literacy, but also those ones from hard to reach communities, but also those who are under 18 or from poorer socioeconomic backgrounds. We want to also understand what do people need to do to tweak the model locally to make it work. What adjustments, refinements do people do that other people could learn from rather than having to reinvent the wheel every time we go there. Also, we need to figure out how we work closely with local authorities. This is very much working in conjunction, as I said before. It's not in addition to, and we want to make sure that we highlight where people can work well together. That could involve in-reach. It might involve actually step-down care when people leave hospital, but it will be different in different areas. We've got to understand that different local authorities have different systems, and we need to make sure that we work in partnership there. Lots of things around barriers and culture. We've really got to take areas of the NHS and turn around and say we are part of the problem. We are not doing what we should be doing, and this is the opportunity with more money coming into the system. Just to allude to Sanjay's talk, we've got to follow the money. The money is coming in. We really have got the opportunity to make a difference here and to break down those barriers and to actually take some ownership. So that's what we want to do. We've got the opportunity to share learning materials, to generate those across the early implementer sites, and we've also got the opportunity to obviously understand what do we do in light of COVID and the second wave that's happening at the moment. How can we adjust these models to make them work in light of hot and cold wards, green and red wards? So what are the early implemented sites, or who are the early implemented sites, should I say? We've got early implemented sites across most of the regions, testing different types of the model. So in Manchester, we're acknowledging Cure, as Sanjay alluded to, as one of the early implemented sites. We're looking at supporting their smoking in pregnancy programme, and we're working with Blackpool, who have some of the highest SATOD smoking rates, so we're particularly focusing on maternity there. Looking at South Yorkshire and Bassett Law and East London Foundation Trust when we're talking about the mental health model, and they will both be at an ICS footprint level. And then we're also looking at working with Bristol, North Somerset, South Gloucester and Nottingham and Nottinghamshire from a maternity model, with the acute model focusing on Great Yarmouth for a coastal area in east of England, and working across Kings and Guy's and St Thomas's in London. That said, these are the early implemented sites getting funding over the course of the year. We do have a community of practice, which I'll allude to in a minute, but everybody's welcome to join in. An exclusive club. Money will be coming into the system, and people don't have to wait for this funding to come down to get started. Indeed, Sheffield are actually expanding what they're doing beyond the early implemented sites. Manchester, as we know, had already get started, and we know there's some good work happening in the northeast, as John has alluded to, and also on the Wirral that I'm aware of. So people are getting started without necessarily being acknowledged as an early implemented site. So 21, 22 and beyond, I think what we will say is that we're in challenging times at the moment. There's lots of levels of uncertainty with COVID, and we need to recognise that whatever we're planning now may be impacted upon by the pandemic. But what we want to do is really lay out the intention is still to deliver the full commitments of the long-term plan. It might mean we need to start things a little bit later and progress at more speed later on, but we've got to be sensible about what we're asking the NHS to do. However, money will go down to systems, it will go down as part of their transformation baselines, and so systems will from next year be able to look at that and think, what are we going to do locally? And so there's the ability at a system level or a provider level to actually influence where people actually target their money in the first instance. They need to prioritise it. They might want to make sure that everybody gets a little bit of money across the course, or they might want to focus on just a couple of areas and really nail down, let's say, roll out 100% of smoking tobacco treatment services in the maternity services locally, and then focus on inpatients at a later point. But just to reiterate again, people don't have to wait for the long-term funding. So I think just my last slide, it was just to say that we are putting the money in. This is part of our support offer. We have the early implemented sites. We will draw out as much learning as we can around that. There are other things that we're putting available, and they are available on our community of practice, such as the delivery model, and we're developing some data collection templates and learning resources. There is a non-mandatory tariff out there if people want to look at that, if they want to use some kind of financial mechanism. I know we're moving away from tariff at the moment, but it's there if people need it. And there is a community of practice. At the moment, it is just the Future NHS website, which is a website with lots of resources on there. There are some chat functions, etc., but it's very much just a point of sharing lots of information for people to go on, get job descriptions, so you don't have to reinvent the wheel and the such. But we will be building more in there around the clinical case, working with partners such as ASH, with the British Thoracic Society, to try sort of build that bigger community of practice around there, which is a little bit more interactive. But hopefully I'm to time, so we're finished there, but there is the link that you will be able to access through my slides to get to the community of practice should you wish to join it. But thank you.
Thank you so much, Paul, and it's good to see my local hospital, King's, as one of the early adopter sites. So I hope